بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله هنكمل باقي البرزنتيشن للأونكونفرولوجي وأي كونسلتيشن، أي استشارة بتجيلك من قسم الأورام، وخاصة أي كسور كلى وحاد أو كسور كلى مزمن إذا AKI or CKD. How you can deal, how you can to approach to your patient with AKI in oncology department, either related to the primary disease or related to the chemotherapy, and we'll see how you can deal with different cases. بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. لا نبدأ بالصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. Our objective today، الهدف من المحاضرة دي اليوم: how common is AKI in cancer patient? What does AKI mean for cancer patient? How should we approach AKI in cancer patient or no? What are cancer specific causes of AKI? الهدف اليوم من المحاضرة هل ال AKI ديت بتشوفها كتير في حالات الأونكونفرولوجي؟ طبعا بدأ بالجروين and new chemotherapy already. Many patients already referred to nephrology for AKI. What does AKI mean for cancer patient? AKI means you will delay the management and you will delay treat his primary disease cancer, and this will affect, because this AKI you should stop the medication or withdraw medication or decrease the dose or modify dose, and this will affect your management of cancer. How should we approach AKI in cancer patients? The same general approach I discussed in details in our previous presentation in AKI in details. How you can approach the AKI as a pre-renal, renal, and post-renal, same as in AKI. What are cancer-specific causes of AKI? And we'll discuss all this type by details. Onco-nephrology is our subdivision nephrology, just responsible for any AKI or CKD in oncology patient, just to prevent and manage kidney complication in patient with cancer, improve cancer care in patient with chronic kidney disease, because this will affect the dose and need dose modification and decrease the dose, and this will delay or just prolong your management for cancer. This bad kidney injury associated with different cancer, as here, all and breast and obstetric patient, and the breast and lung and the colorectal, all this associated with AKIs is different. Study different causes of AKI presented by studies is Burma study. The percentage of patient with kidney injury is defined by serum creatinine and GFR. Estimated GFR more than 90 or less than 60, and all this shows just different causes of AKI, and we'll discuss in details who's the common. Just will depend on this serum creatinine and the estimated GFR. We'll see on the next slides. Just to show this slide, to show the relation between the risk factor to precipitate for cancer or chronic kidney disease. We have common risk factor either lead to cancer or same times AKI and the kidney disease or chronic kidney disease, like smoking, hypertension, obesity, toxic exposure, and analgesic, hepatitis C, sickle cell disease, diabetes mellitus. All this can lead to chronic kidney disease, and all this also risk factor for renal cell carcinoma. And even chronic kidney disease may be like our hemodialysis patient, if develop new cyst or discover this patient with hematuria or erythrocytosis. We found this new cyst. This cyst may be transformed into malignancy and will end by renal cell carcinoma, and also renal cell carcinoma, loss of renal mass, hyperfiltration. All this can lead to CKD. This is the benefit of this dilemma. Everyone lead to others. Either chronic kidney disease can lead to the renal cell carcinoma, or renal cell carcinoma can lead to chronic kidney disease, and this risk factor for both either CKD or renal cell carcinoma. Here also this patient with cancer, any patient referred for you for cancer, either AKI or chronic kidney disease related to disease risk, either post-renal obstruction from tumor obstructed already like prostate or urothelial tumor. Hypercalcemia also can lead to AKI, renal cell cancer, nephrectomy ended by AKI, paraproteinemia associated with this cancer also can lead to AKI. We discussed paraproteinemia in details in the first presentation in onco-nephrology. Patient with counter iatrogenic risk factor like chemotherapy can lead to AKI, target therapy, immunotherapy, and this neotherapy immune checkpoint, and we'll discuss all this in details. Nephrotoxin, either patient receive IV contrast or non-steroidal volume depletion, infection, and sepsis. All this also can lead to AKI, and some related to kidneys. The problem in patient with CKD may will delay management and dose modification, decrease the dose. All this will lead to a worsening the cancer outcome because your kidney already impaired and you need to decrease the dose like that. And it will not give full management for your patient, and this will delay management and treatment of your patient cancer. For being to be a good nephrologist, you should know these myriads of clinical syndromes, nephrotic syndromes. What is the criteria for nephrotic syndrome? We discussed this in details before. Hematuria, proteinuria. This is what means active urine sediment. If you send urine analysis and found red blood cells and white blood cells and red blood cell or dysmorphic red blood cells and protein in urine, this means active urine sediment is hematuria or proteinuria. And acute kidney injury and rapidly progressive GN, you should know all this in details, how you can deal with this AKI, acute AKI, sudden onset AKI or rapidly progressive GN should put in your mind in any patient. Fanconi syndrome, unexplained CKD, you have to be excellent general nephrology if you know all this, and how you can deal with onco-nephrology patient, especially with AKI or CKD patient. Just we'll start by this multiple choice question. Which of the following malignancies has the highest 1 year risk of AKI? What do you think? 1 year risk, highest AKI from the first malignancy, either multiple myeloma, lymphoma, renal cell cancer, and liver and leukemia. To be easy for you, we are discussing nephrology. You are nephrologist, is a renal cell cancer. This is the correct answer is C, renal cell cancer. All this cancer are associated with AKI risk, but the renal cell cancer was found to have the highest 1 year risk in cohort study, examining the incidence of AKI in cancer patient. In patient with recent diagnosis of cancer, which of the following complication is increasing the setting of the cancer diagnosis? ايه الكومبليكيشن اللي بتزيد مع الكانسر في العيان النفرولوجي AKI or CKD or mortality? I think all of the above increase when any patient with cancer either related to cancer or related to chemotherapy or complication of both. Cancer is associated with increased risk of AKI, CKD, and overall mortality. These complications are result of the tumor itself, infiltration or tumor product during nephrotoxicity from or comorbid disease or all of the above. All this associated with only in the by AKI and CKD and overall mortality. We'll start today our the first consult for us, referral for us, 69 years, this is real case already, 69 years old man, referred for AKI. This patient with metastatic lung adenocarcinoma in April 2020, with metastatic to left adrenal and liver brain. With patient with lung adenocarcinoma and metastasis already to liver, brain, and left adrenal, past medical history, dyslipidemia, ex-smoker, 22 packs years per years, and medication already, folic acid, vitamin B12, atorvastatin, pantoprazole, put in your mind, any patient with AKI onco-nephrology. In PPI, you should think also this will precipitate more acute interstitial nephritis. This patient already started for this lung adenocarcinoma, started cisplatin and pimitrixide and pembrolizumab, this immune checkpoint. This 3 chemotherapy for this disease in May 2020. He started cisplatin, pimitrixide, and pembrolizumab. Already this patient started in this 3 chemotherapy patients. This treatment course, normal baseline kidney function, creatinine 85 micromole is normal, micromole, and estimated GFR is 80, and cisplatin, pimitrixide, and pembrolizumab they already started 4 cycle from May to July 2020. Maintains treatment with pimitrixide and pembrolizumab from August 2020. He started in this, received 4 cycles of cisplatin and the other medication, pemetrexed and pembrolizumab, and already maintenance treatment, pemetrexed and pembrolizumab from August 2020. To early September 2020, stopped all this maintenance medication, this pemetrexed and pembrolizumab. Already all this stopped because this patient developed AKI and the creatinine increased from baseline 85 to increase 217 to 217. In patient already on September 2020, creatinine increased from normal 85 to 217 and estimated GFR now from 80 to 26 ml per minute. Ultrasound kidneys is normal size with no hydronephrosis. Urine analysis, no hematuria, no proteinuria, white blood cells 15 cell. Little bit query. This white blood cells is not to ensure maybe acute interstitial nephritis. Take care, not only just UTI. We have now acute interstitial nephritis, maybe with white blood cell custard you can catch under microscope. And already this patient with proteinuria 2.7 grams, microalbuminuria, milligram per millimole, and GN workup negative for C3, C4, ANCA, and in hepatitis, and this PEP also negative. Serum magnesium 0.8 is normal because the patient on cisplatin. Other all GN workup is normal, and now ultrasound is okay, no post-renal. Now this rule out post-renal, and this only just white blood cells, only in urine, this with acute interstitial nephritis, maybe UTI, and with this proteinuria, also with this microalbuminuria, this patient already with this maybe the acute interstitial nephritis, all GN workup is negative, magnesium is okay. 3 potential nephrotoxic now treatment, AKI secondary to cisplatin, pemetrexed, and pembrolizumab. All these 3 potential nephrotoxic treatments lead to AKI. This can cause alone AKI, and this also can cause alone AKI, and this also can cause AKI. We'll discuss each one in details. Case 1, differential diagnosis, cisplatin-related nephrotoxicity. Cisplatin is platinum salt-based chemotherapy. Cause tubular toxicity, delay in the tubules. AKI is a risk factor for AKI. 20 to 30% of the patient will develop AKI within 3 to 7 days, within a week of therapy. And you're in non-specific, no or low-grade proteinuria, CKD progression, progressive CKD from tubulointerstitial fibrosis, tubulointerstitial fibrosis with cisplatin. Electrolytes, mainly hypomagnesemia and Fanconi-like syndrome, also can caused by cisplatin. Tubulointerstitial fibrosis is the main pathology now. If the patient is on cisplatin, this cause of AKI, and also hypomagnesemia, Fanconi syndrome you can see, and really use thrombotic microangiopathy and salt wasting, renal tubular acidosis also can be seen. Cisplatin is a platinum compound, as we saw that effectively for many cancers, effective treatment for many cancers. Major adverse effect of is nephrotoxicity and ototoxicity. Both are those related toxicities. Apoptosis and necrosis is a mechanism of nephrotoxicity. Nephrotoxic manifestation include tubulopathy. The patient Fanconi syndrome, salt wasting, magnesium wasting, and nephrogenic diabetes insipidus. AKI increased vascular resistance and tubular injury, tubulointerstitial nephritis with ATN, thrombotic microangiopathy, HUS also seen rarely. Nephrotoxicity is often reversible but can be permanent with CKD and chronic tubulopathies. Prevention of AKI and tubulopathies with cisplatin, forced diuresis with IV normal saline, and you can use this like antidotes, amifostine and the sodium thiosulfate. All this decrease the toxicity from cisplatin, or you can use other platinum like carboplatin or oxaliplatin. This is less nephrotoxic than cisplatin. Not transported by OCT. This is a mechanism of cisplatin. And also we'll see how to can prevent, as we mentioned, normal saline, diuresis. We need more urine output to clear this cisplatin from our body. saline plus mannitol to induce more diuresis, or saline plus furosemide, avoid potential nephrotoxin, but other nephrotoxin like PPI or other antibiotics, lower dose of cisplatin, or using alternate to cisplatin like carboplatin, and the magnesium supplementation if your patient hypomagnesemia. This is the main management. Just decrease the dose or use other other platinum like carboplatin or oxaliplatin, and digest a huge amount of normal saline with mannitol or Lasix to induce more diuresis, and avoid any other nephrotoxin and correct electrolytes, especially hypomagnesemia. Case 1, second differential diagnosis, p-methoxide-related nephrotoxicity. This is p-methoxide anti-metabolite derivative of methotrexate. I saw one patient the creatinine reach around 600 with methotrexate management for melanoma, I say, and because of tubular toxicity. AKI low risk in monotherapy, 1 to 5%. Higher up to 50% when used with combination of chemotherapy. Risk of nephrotoxicity increase with prolonged exposure, accumulation of p-methoxide polyglutamate derivative within the renal cell. And CKD, tubulointerstitial fibrosis, same mechanisms. Tubulointerstitial fibrosis may lead to distal RTA, normal anion gap, metabolic acidosis, and nephrogenic also diabetes insipidus, already insipidus with p-methoxide like methotrexate. And our management for any methotrexate toxicity, we'll discuss this in details. Just keep your urine pH more than 7.5, more than 8 if you like, to decrease the toxicity and increase the solubility of this medication to be excreted in urine. Acute tubular injury, ATN, tubulointestinal nephritis with cisplatin, fosfamide, zoledronate, pentostatin, imitinib, and bimetrexate, and other lead to acute tubular injury and ATN, tubulointestinal nephritis. Don't forget cisplatin, fosfamide, zoledronate, ATN, pentostatin, imatinib, and bimetrexate, and other medication. Fosfamide, how to prevent fosfamide, like we are using to decrease toxicity from cyclophosphamide, we use mesna. We are same mechanism here. We can use mesna given with fosfamide of limited value, dose reduction, and cimetidine also can be used. Treatment, supportive care, supplement electrolyte, any electrolyte, and monitor for any electrolyte disturbance long term. May lead to permanent tubulopathy and isolated renal phosphaturia. This may cause osteomalacia and other osteoporosis in elderly. There's a fosfamide also, how to manage anti-prevent toxicity. Crystal nephropathy, like methotrexate, as I mentioned, we saw one patient already 1 month back, can lead to acute kidney injury or acute or chronic nephrotoxicity, AKI or CKD, resulting from precipitation and deposition of crystal, often uric acid, methotrexate within the renal tubular lumen. Risk increase with tubular urine flow rate are low. Volume depletion. If the patient volume depletion, this will increase the risk of AKI with methotrexate. Our aim of management just to use isotonic bicarb. At that time, we are using around 200 ml per hour isotonic bicarb. This is 1 liter D5 water plus 150 sodium bicarb in each liter of dextrose 5 water. And continue infusion 200 ml per hour, and you can use according to your patient tolerated and his echo and his ejection fraction and the cardiac stability. I don't know what is the ejection fraction of your patient, but this patient need aggressive IV fluid, especially with isotonic bicarb. And also we can use sodium bicarb tablet, highest dose as you can. We can use 2 gram or 1 gram TID or QID every 6 hours. Also, we can use acetazolamide if your patient develop metabolic alkalosis at that time and respiratory acidosis. We can use at that time acetazolamide. Our aim to management any methotrexate toxicity just to increase urine pH, to keep urine pH more than 8, and you can check urine pH every 2 hours to continue your management. And this is the aim of this methotrexate management. Methotrexate 90% cleared by kidney, precipitation methotrexate crystals and tubules, Urinary alkalization is the main issue in your management of this patient to keep the urine pH more than 8. And what else? Continue isotonic bicarb plus oral bicarb aim to keep the urine pH more than 8. If your patient develops metabolic alkalosis and respiratory acidosis, like patient with congestive heart failure and aggressive dose of diuretic, we can use at that time acetazolamide. Check your urine pH every 2 hours to keep more than 8. Okay, and don't forget the antidote for methotrexate is dolucarbidase. Dolucarbidase, this antidote, and this increases solubility of this methotrexate and decreases nephrotoxicity from glucarbidase. Okay, this is a glucarbidase. This with the live fluid, isotonic bicarb, oral bicarb to increase alkalinity of your urine. As I mentioned before, this chemotherapy, cisplatin, fosfamide, methotrexate, tabin, mitomycin, bimethrexate, and bimidronate, zolidronate, all this lead to this syndrome. Most of this lead to AKI with Fanconi syndrome, nephrodenic diabetes insipidus. Most of them also can lead to acute tubular injury and tubular interstitial nephritis. To mention here, the cisplatin, the most common one, 25 to 30% in precipitation of AKI, followed by phosphamide, then bimethrexate, methotrexate less than 5%, especially in volume depleted patient, increase the risk. All this is a high risk with cisplatin to induce AKI. Case 1 differential diagnosis, pembrolizumab related nephrotoxicity. This is immune checkpoint inhibitors. Anti-program this one also inhibitors. This pembrolizumab, the immune checkpoint inhibitor, and we'll discuss this in details. Also can be differential diagnosis for AKI. This immune checkpoint inhibitors is enhance the immune response, lead to activation our T cells, lead to damage or destroy our tumor cells or cancer cells, allow host immune cells to identify and eliminate tumor cells, risk development of immune-related adverse event. Immune checkpoint associated with development acute interstitial nephritis. This immune checkpoint lead to acute interstitial nephritis or granulomatous interstitial nephritis. Renal replacement therapy needed in some patient. Time course variable, maybe early or late according to the emergency indication for your renal replacement therapy and the time of consultation or nephrology intervention. Early is better than late. And the best management for this immune checkpoint, AKI or nephrotoxicity, just to withdraw the medication and start steroid and withdraw any other combined medication like the BBI for your patient, pantoprazole or any antibiotic or any non-steroidal, and we'll discuss the mechanism. You know, our program, this program, this one, L1, and the program this one. You know the mechanism. What is the mechanism? In summary, to understand this, we have already a normal T cells. These T cells lead to damage this tumor cell in a normal response. If your body activates this immune checkpoint, if the immune checkpoint just lead to disturb this mechanism. Normally, our T cells, this we have already our immunity. We have humoral immunity, this antibody-mediated immunity, and cytotoxic T cell immunity, responsible by T cell to kill any virus, any organism, any foreign bodies, or any cancer cell. Lead to the responsibility to clear our body from cancer cell, from any infections. This is the T cell. We need our T cell to be active to damage this cancer cell. If we discover in patient with cancer, we have more proliferation of this immune checkpoint. This immune checkpoint already is this red one and the blue one already just this cancel or just what may lead to this T cell unactivated and lead to more proliferation and grow in your cancer cell because your T cell now inactive because this immune checkpoint. Immune checkpoint here lead to, when you join to T cell receptors here, lead to inactivation of this T cell, unable to damage this cancer cell. By this immune checkpoint inhibitor, this PD-1, PD-L1, and the CTLA4, all this will be inhibited by this immune checkpoint and lead to this destruct this immune checkpoint and lead to more activation of our natural innate immunity and activate more T cells and lead to the damage of our cancer cells. And that antigen presenting cell, as we know, this presenting this tumor cell or foreign bodies to our T cells. This help to damage this more cancer cell. In clear, to be summarized, our normally T cells responsible for damage any foreign bodies, viral, bacterial, and cancer cell in our bodies. We have a patient with cancer, we discover this immune checkpoint lead to bind to T cell receptors, lead to inactivation of our T cells. We need some medication or some monoclonal antibodies or some immune therapy lead to inactivate this immune checkpoint. This checkpoint, this blocked T cell receptors lead to inactivation of T cell to damage our cancer cell. This what means by this new chemotherapy immune checkpoint just to enhance our innate immunity T cell to damage our cancer cell. And all this the same in details for our mechanism also here. The dendritic cell just is antigen presenting cell that presenting any foreign bodies to T cells lead to damage of these T cells. And this already will be locked or inactivated by the immune checkpoint. We are using this immune checkpoint inhibitors lead to block this immune checkpoint and lead to activate our T cell to kill this tumor cells. Just in summary, these monoclonal antibodies, as we mentioned, the immune checkpoint, monoclonal antibodies inhibit immune checkpoint. Checkpoint just block T cell receptors that join to tumor cells, lead to damage or destroy our tumor cell, lead to activate our T cell, lead to activate our immune system, and just to take care from this side effect from this medication. Also same here with the chimeric antigen T cell receptors, the same mechanism here also. We need to inhibit this because this CTLA4 binding lead to inactivation also T cells. We need to inhibition of this CTLA4 inhibitors binding and lead to also activation of our innate immunity and lead to damage or destroy our T cells. From this inactivation of our T cells lead to cytokine release syndrome, around 40% inflammation, vasodilatation, hypotension from this reaction, and also lead to cardiomyopathy, sometimes end by cardiomyopathy 25%. All this will end by inflammation, sepsis, and vasodilatation, hypotension with cardiomyopathy will lead to hypotension, and this decrease perfusion to the kidney and lead to acute tubular necrosis. This chimeric antigen receptor T cell inhibitors also is the same mechanism because it's decrease our T cell activation. We need to inhibit this also checkpoint or receptors to lead to more release and activation of our T cell to kill cancer cells. I know it's difficult to know the mechanism. If you can read details this as you like, but I try just to summarize because I have long presentation today. And just to put in your mind, just this, with all this medication, just to enhance our innate immunity, our T cell, just to release our T cell to do her job in our body to kill any foreign bodies or cells or virus or bacteria. Just to manage our patient, just like any patient with just IV fluid, vasopressor, steroid, and tocilizumab. All this because the tocilizumab here will join with interleukin 2 cells that lead to cytokine release. This already inhibited by tocilizumab from this medication cascade. Our job here to monitor our patient and prevent any medication and the progression of AKI and anticipate what is the patient will be recovered or will be need dialysis or whatever, and and try to for just treatment, either medical or intervention by renal replacement therapy, and to monitor renal recovery and resume his main treatment for the main disease, cancer, by chemotherapy. Differential diagnosis: pembrolizumab related nephrotoxicity, dominant pattern of injury, acute interstitial nephritis. This is immunocheckpoint. The main kidney histopathology is acute interstitial nephritis, 50% sterile pyuria, 23% hematuria. Proteinuria is generally modest, 0.1, 0.9 gram per day, less than 1 gram per day. Allergic triad is extremely rare, 10% of eosinophils. Time from initiation of immunocheckpoint inhibitors to AKI is variable. Majority of the patient concurrent immune-related overdose event, the immune-related adverse event. The majority of the patient develop this side effect around 60 to 80%. Most common coexisting immune check-related adverse effect: thyroiditis and colitis. This is observed already in this medication: thyroiditis and colitis. Our differential diagnosis: clinical presentation not specific, urine analysis no proteinuria, plus just only leukocyturia, as we mentioned before, leukocytes. And AKI 3 months after starting treatment, need to complete investigation with kidney biopsy. AKI after 3 months of starting in management, need to complete the investigation. This patient need to be a kidney biopsy done for him, and already kidney biopsy, if you saw by this long section already under light microscope, we found this multiple cell interstitial, the interacute interstitial nephritis, 3 of 25 glomerular sclerosed, mild interstitial fibrosis, tubular atrophy, no arterial hylinosis or arterial sclerosis. Just the main issue here: mild interstitial fibrosis, interstitial here, fibrosis. These multiple blue dots, this interstitial inflammatory cells already with acute interstitial nephritis, and we see here there's multiple cells in between the renal tubules. All these renal tubules, all this interstitial inflammatory cells. Acute interstitial nephritis are associated with pembrolizumab. Pembrolizumab already in hold. We advise, our recommendation as a nephrologist, to hold this medication. Also PPI. PPI pantoprazole stopped already, a risk factor also. Corticosteroid treatment, prednisone 1 mg per kg up to 60 mg per day. Already started September 11 for 2 weeks, followed by taper over 6 weeks. Now prednisone 10 mg per day, and the creatinine reach from 217, 125, and the GFR from 30s to 50 now. And patient is partial recovery or in recovery already from this, because we stopped this and started this steroid for him. And this is the 4th cycle already received with the 3 medication, and started here. This is maintenance therapy. This is the cycles. He receives 3 cycles from cisplatin and pemetrexed and pembrolizumab already here. He received all this cycle from March here, I think, until August, and start to be in maintenance here in August. And I started with creatinine increase. The prednisone started here, and the creatinine started to be slowed down again until he reached here 125, and the prednisone taper already. And we'll see, we'll follow the patient. Case 1 outcome: patient will resume pemetrexed soon, will not receive further no more cisplatin. Estimated GFR more than 45% ml per minute. Close co-management with nephrology and oncology. Consider challenge with pembrolizumab, this is immune checkpoint inhibitors. If creatinine continue to improve, risk of recurrence with re-challenge. Discussion with patient and risk. With the patient and risk benefit is the key. You should discuss with your patient before you resume this chemotherapy again. What is the risk and the benefit to manage your primary disease or to protect your kidneys? We have GN or glomerular injury pattern and immune checkpoint inhibitor nephrotoxicity. We have focal segmental membranous GN and minimally changed disease. The 3 non-proliferative nephrotic range proteinuria or nephrotic or proteinuric GN with proliferative IgA ANCA has been reported. Partial to complete remission has been achieved in most of cases with discharge of immunotherapy, with discontinued immunotherapy and use of steroid. Most of the cases lead to partial to complete remission after discontinuing this medication immune checkpoint inhibitor. Some of them relapsed after resuming on steroid, on resuming immunotherapy, or in tapering of steroid like focal segmental IgA and minimally changed disease. We'll observe some relapse for that. Pathological features of renal immune checkpoint renal adverse event. Most common lesion is tubulointerstitial nephritis. However, minimally changed disease, focal segmental glomerulosclerosis, and membranous also, and thrombotic microangiopathy. And ANCA vasculitis has also been reported. All this can be seen with the immune checkpoint inhibitors, not only tubulointerstitial inflammation or nephritis, maybe also some most common GN, minimally changed, membranous, focal segmental, also thrombotic microangiopathy or ANCA, or also IgA nephropathy. Exact mechanism is still unknown till now. Current immunotherapy-based combination drugs and indication in nivolumab and ipilimumab in metastatic melanoma, renal cell cancer, and colorectal cancer, also prostatic carcinoma, nivolumab and ipilimumab. This all immune checkpoint inhibitor. Just remind the name, because if you will see any patient in onco-nephrology department, you should know what is the medication and what is your primary cancer. Don't forget this MUMAB, this immune checkpoint inhibitor, and this pembrolizumab also, and plus other chemotherapy, non-squamous cell lung carcinoma also can be lead to this type of immune checkpoint inhibitors. Anti-CTLA4, you know, CTLA4 is bound by CD28, and this will lead to inactivation of our T cells to destroy tumors. So we need to block this CTLA4 with by ipilimumab, this anti-CTLA cytotoxic T lymphocytes type 4 inhibitors to activate our T cell to destroy tumors, and the nivolumab and the pembrolizumab and the other plimimab, and also this all anti-program. This one, all this lead to activation, also release, just block all checkpoint that will inhibit our T cells to destroy our tumor cells. So all this immune checkpoint inhibitors lead to activation our cell, and anti-BD program, this L1 and also other this like atezolizumab. All this lead to also activation our T cells and lead to damage our cancer cells by T lymphocytes. Again, by indication for each anti-CTLA cytotoxic T lymphocytes, ipilimumab is used in metastatic melanoma, the renal cell carcinoma, nivolumab, already metastatic melanoma, and the cancer, colon cancer, and urothelial cancer, and prostatic, and anti-PD1 and the PDL1 also. Like this name, you can read the pembrolizumab and the other atezolizumab, all this immune checkpoint inhibitor, we can read later. Immune-related side effect like hypo or hyperthyroidism, this thyroiditis, as we mentioned, and type 1 diabetes, adrenal insufficiency, hepatitis, pneumonitis, hypophysitis, dermatitis, colitis, diarrhea, and AKI. I know it's difficult terms and difficult division in nephrology. This is onco-nephrology and new growing field in nephrology now, and more cases refer to nephrology from onco-nephrology. We should know names, and we should at least take a hint or take just background. If you have any consult or in your clinic, if you face any patient with onco-nephrology, and you should know all this. You should know as a nephrologist. And this is the side effect of immune checkpoint, either thyroiditis, hypo or hyperthyroidism, type 1 diabetes, and adrenal insufficiency, hepatitis, pneumonitis, hypophysitis, dermatitis, colitis, diarrhea, and also don't forget AKI is the main side effect. Again, all these names, as we mentioned, all end by MOMAB or LUMAB. Just don't forget this immune checkpoint inhibitor, all lead to acute kidney injury, as we see here. All either tuberous nephritis or ATN or whatever, or GN related. Immune checkpoint nephrotoxicity already, this is already trial done already by our team, Dr. Miraz, already in Yochen. This is immune checkpoint inhibitor nephrotoxicity and acute kidney injury in 309 patients with incidence around 17% of AKI and adverse effect on hypertension and not associated with increased mortality. All this aside our risk factor, we'll see we have 2 cases discovered with minimal exchange disease, and the other 2 cases with membranous nephropathy, and the 2 cases with TMA, and the other maybe tubular interstitial nephritis. Most of these cases we'll see now. Just when you see this patient, just evaluate your patient pre-renal, renal, post-renal, and stop this immune checkpoint, and you can start. This is your management and evaluation, and this is our job to prevent, to monitor, to anticipate, and detect, and treatment, either medical or intervention by dialysis. Cancer patient receiving immune checkpoint inhibitor develop AKI, either AKI stage 1 or stage 3 or 2 or 3, and we'll mention later. And we discussed this all details in AKI presentation before. If your patient is just stage 1, AKI resolve, continue immune checkpoint inhibitor, AKI progress and stop. You should stop. If you AKI progress, you should stop immune checkpoint therapy and go to evaluation, just to call nephrology consult to stop the first step and stop your immune checkpoint. If AKI due to an immune checkpoint nephrotoxicity here, either by obstruction, just to call urology to solve the problem. If AKI or medication, you can stop this medication. If potential nephrotoxicity, either no immune checkpoint adverse event, blood urine, nothing granular cast, you should go to, if no active urine or blood urine, not with interstitial nephritis, just go to kidney biopsy, and we'll see what is your either acute tubular interstitial nephritis or GN, and we'll see what is the treatment of if your patient with AKI stage 2 or 3 with potential immune checkpoint related nephrotoxicity, and already with this trial pyuria or white blood cell cast, this treat with steroid direct, no need for biopsy. AKI progress or does not recover, just will go to kidney biopsy. If just this is the benefit of this diagram. Just AKI stage 1, just stop any medication or any nephrotoxic medication, okay? If your kidney resolve, resume your cancer therapy, immune checkpoint. If your kidney not progress, we'll go to stage 2 and 3 and consult nephrology and stop your immune checkpoint. Just nephrology will see pre-renal, renal, post-renal. You should rule out post-renal. If your patient already with obstructive uropathy, call urology and solve the problem, and observe your AKI recovery after urology intervention. If you think this is related to nephrotoxicity, no obstruction, just check the urine, just under microscope. You will see white blood cells or white blood cell cast or no. If you will see white blood cell or white blood cell cast, this is with acute interstitial nephritis. Just stop your immune checkpoint and start steroid and follow your patient, check response. If respond as well is okay. If not respond, just go to kidney biopsy like other patients with planned urine. Immune checkpoint inhibitor and kidney immune related adverse event, multi-system immune related adverse event are common. Acute interstitial nephritis is the most common nephrotoxicity, acute interstitial nephritis with an immune checkpoint, with high creatinine, pyuria, white blood cell, cast, all this, proteinuria. Reflex kidney biopsy should be discouraged until corticosteroid treatment has been attempted postum. Yeah, if you suspect your patient acute interstitial nephritis by you should start steroid, and if no response at that time, we can think in kidney biopsy or no. And this immune checkpoint adverse event, all this mentioned in this picture, you can take a picture and you can read later. This immune checkpoint, uveitis, rhinomyositis, vitiligo, myocarditis, pancreatitis, colitis, enteritis, vasculitis, hepatitis, and thrombocytopenitis, thyroiditis, hypophysitis, encephalitis, septic meningitis, all this side effect you can see in your patient in immune check therapy. Okay. Immune checkpoint inhibitor assistance that's and the risk of immune checkpoint. Around 17% of patient experience here AKI, but only 4 patients had AKI adverse side effect from this immune checkpoint. Other acute interstitial nephritis related drugs are not associated with immune checkpoint AKI. This as regards this studies and your chain. This 17% after immune checkpoint develop this develop AKI. 17% of the patient from 309 patients, only 4 patients had kidney-related adverse side effect from this immune checkpoint. Other acute interstitial nephritis-related drugs were not associated with immune checkpoint AKI limited powers. And we mention here also the same acute kidney injury 17%, sustained AKI around 8%, checkpoint inhibitor related adverse effect around 3% from this 1,016 patient. This is the frequency of AKI in with the immune checkpoint inhibitors, and follow up around 1 year, and already sustained AKI around 2.8% in comparison with 2.2 already here, around 2.4% with immune checkpoint sustained AKI. BBI already here used as a combination with immune checkpoint treatment associated with increased risk 40 and 45% complete partial recovery respectively after was stopping this medication. What this would mean with increased risk also with BBI with immune checkpoint inhibitors in acute kidney injury and acute interstitial nephritis. Kidney recovery with better survival here, better than a patient will remain in the CKD or deteriorate kidney function. If kidney recovery, this will give you better survival here and the y-axis. And this kidney immune-related adverse event as regard the reach challenge. To start treatment again or no, we'll see factor favoring quick taper and immune checkpoint reach channel. Kidney immune-related adverse event, immune checkpoint reach-challenge factors favoring quick taper and immune checkpoint reach-challenge. No other severe immune-related adverse event like myocarditis, myositis, pneumonitis, hepatitis, and meningitis. AKI recover quickly and with steroid. Other acute interstitial nephritis triggers like BBI can be discontinued. Acute interstitial nephritis immune-related mediated glomerulonephritis, newly started therapy, melanoma, or other immune checkpoint sensitive tumor. All this you can reach challenge your patient with immune checkpoint if you have this criteria with AKI recover rapidly and you remove already BBI and other triggers for acute interstitial nephritis. You can resume your immune checkpoint again. Kidney immune related adverse event in immune checkpoint reach-channel factor favoring the long steroid course and avoid immune check reach-channel. AKI slowly recovering, still partial recovery with proteinuria, quercetin, not triggered by no other risk factor like PPI or non-steroidal, other life-threatening. If you have life-threatening pneumonitis or meningitis, immune-related adverse event, pancreatitis, or metastatic malignancy that is not particularly sensitive to immune checkpoint, if you have why you resume, you will kill your patient. Just risk-benefit here, you should weigh the risk-benefit for your patient, longer duration of therapy, suggesting that whatever benefit are to be gained have already been realized. Just I need from this slides, when you resume immune checkpoint, and this slide and this slide, when you resume and when you not resume. When you resume, if you have good recovery of your kidney function and has a risk factor like PPI or non-steroidal to induce acute interstitial nephritis, you can resume at that time. If your kidney just partial recovery and still your no other triggers for AKI and metastatic disease, why you will be hurry to recover, no hurry to reach your patient again. Case 2, referral for AKI in setting of metastatic renal cell carcinoma. Case number, we finished already case number 1. We knew this immune checkpoint inhibitors. I know it's a difficult topic, but it's new chemotherapy and you should know. And even new oncology department for us and the oncology subdivision in nephrology. And you should take a hand to, if you face any patient with onco-nephrology with AKI, how you can approach. This case scenario covers 3 most common chemotherapy. Please, you can deal, we can just give you a hint how to approach or to manage your patient as AKI in onco-nephrology. Case number 2 refers to nephrology as a consult in AKI in a setting of metastatic renal cell carcinoma. 55 years old, the old male patient with metastatic renal cell carcinoma received nivolumab. Nivolumab, this immune checkpoint inhibitor, 2017, with left nephrectomy 2018, zoledronic acid 2019, creatinine based AKI once, I don't know, AKI or CKD referred by creatinine 170 micromole, albumin 27, proteinuria 5.5 grams, urine just only trace blood protein, free kappa to lambda ratio 1.4, not significant. Otherwise, this patient now referred for you as AKI with creatinine 170 and albumin low and significant hypoalbuminemia and poor nephrotic range proteinuria, more than 3.5 grams per day. How you can approach to this patient? If you refer to a patient from onco-nephrology, is 55, metastatic renal cell carcinoma, received the nivolumab. Nivolumab, this patient already 2017, and now creatinine referred for you at that time by creatinine 170, albumin like that, proteinuria like that, and the kappa normal. What is the cause of this kidney dysfunction? Is a kidney biopsy needed for this patient? When can cancer therapy be resumed for this patient? Now we have stopped already when we saw this patient, we stop already chemotherapy for him. Kidney risk factor. Patient-specific risk factor, as we mentioned before, for AKI age, more than 65, underlying CKD, diabetes, nephrotoxic medication, non-steroidal ACE, ARBs, PPI, comorbid conditions such as cirrhosis, heart failure, nephrotic syndrome. Cancer-related factor, neutropenia, post-nephrectomy also, risk factor, hematological cancer, tumor lysis, urinary tract infection, sepsis, post-bone transplant, hematopoietic stem cell transplant, thrombotic microangiopathy, tumor lysis, hypercalcemia, neoplastic GN disease, chemotherapy toxicities, all this lead to risk factor for AKI in cancer patient. Diagnostic possibilities already. What is your differential diagnosis for this patient 55 with AKI and nephrotic range proteinuria? Hyperfiltrated related secondary focal segmental because history of obesity, or zoledronic acid focal segmental, or zoledronic acid related ETN, cancer related membranous nephropathy, nivolumab related acute interstitial nephritis, or nivolumab related podocytopathy. We don't know. We have nephrotic syndrome now and patient obese. We receive nivolumab. Nivolumab, we need our differential diagnosis, hyperfiltration, secondary to focal segmental, as we mentioned here in the history. The patient, don't mention here, I think she's mentioned the obese patient already. Just what is the differential diagnosis and what's your differential diagnosis for this patient? Either membranous, minimal chain, interstitial nephritis, just acute tubular necrosis, focal segmental, related to this or no. This is our differential diagnosis. We will do biopsy or not for this patient. Indication for kidney biopsy, hematuria, proteinuria more than 1 gram, unresolved unexplained AKI or unexplained CKD. Solitary kidney visible and the biopsy is safe. There is no increased risk with solitary kidney performed. No contraindication for kidney biopsy if needed. Okay, if you have experts to do kidney biopsy, and the patient accepted the risk and benefit for this kidney biopsy. The indication, as we mentioned, active urine sediment with proteinuria more than 1 gram, and unknown AKI, unknown CKD, or unresolved both. kidney biopsy done shows this already interstitial inflammation as we see here, and I think a epithelial deposition here, and we'll see. Don't forget the risk of the kidney biopsy. As we mentioned before, the frequency on the etiology of AKI in patient receiving immune checkpoint inhibitors. This cohort studied already in 1,016 patients, and 61% at male, strategy for 82% follow-up around 1 year, and proton pump inhibitors, and we'll see. And sustained kidney injury with the immune checkpoint around 2.4 at that time. AKI is common in patients receiving checkpoint inhibitor, and the cause are heterogeneous. Proton pump inhibitor serve as a risk factor for sustained AKI. AKI around 17% develop in this patient, and sustained already in 8%, with immune checkpoint increase more 3%, and with immune checkpoint inhibitor increase around 2.8% sustained AKI. Besides this, on top of this immune checkpoint inhibitor. And this systematic review for immune checkpoint associated with the GN already. The systematic review and meta-analysis, 27 studies, 45 patient already cases of biopsy proven immune checkpoint associated GN, 27% with immune GN already, and renal vasculitis, 24 podocytosis, and 11% C3 GN. Recovery from AKI around 31% from this GN cases, immune around 31% recovery, and 42% partial recovery, and the patient was podocytopathy and remission from proteinuria, 45% complete remission and 38% partial remission. Dialysis dependence from this C3 GN around 19% dialysis dependent. From all this already, recovery from AKI, remission from proteinuria, and dialysis dependence. From all this histopathology, recovery from AKI, 31% for recovery and 42% partial recovery. Remission of proteinuria, 45, complete remission, and 38% partial remission. Dialysis dependence and death, 19% from all this patient. Dialysis dependent and 34% died already. Concomitant already acute interstitial nephritis in 41% already with this GN associated or related immune checkpoint inhibitors. يبقى this systematic review for immune checkpoint inhibitors with associated with GN around from this 27 studies, 27% with immune GN, 24 with podocytosis, either minimal change or focal segmental, or 11% with C3 GN, and recovery from AKI 31%, and partial recovery 42%, remission of proteinuria 45%, complete remission 38%, partial remission, dialysis dependence 19%, and death already 34%. In conclusion, post-immune GN, podocytosis, and C3 GN are the most frequent. Post-immune GN, podocytosis, and C3 GN are the most frequent reported immune checkpoint inhibitor associated with GN lesion, and may be associated with poor kidney and mortality outcome. I know that's difficult, but you should know, take a hint. How would you treat this patient? Dual diagnosis, acute interstitial nephritis, minimally changed disease. As we mentioned here, this is diffuse efficient here, diffuse efficient for podocytes. We don't have any clear podocyte, but I know biopsy is not clear. With acute, this podocyte already diffuse efficient here, effacement of podocytes, and minimally changed disease with acute interstitial nephritis. Just will treatment option steroid. We start steroid for this patient. We can give rituximab, still steroid resistant, and withdrawal immune checkpoint inhibitor. And if still no good recovery, we can permanent withdrawal immune checkpoint inhibitors. Dual diagnosis, acute interstitial nephritis, minimally changed disease, corticosteroid, partial response. Just our patient already started this differential. You should, there's multiple choices, the treatment option, and we did for this patient already started steroid for him with partial response. Creatinine 140 and albumin 38 is improving. Proteinuria 1 gram per day from 5 grams. Future immune checkpoint, just need weight risk benefit until kidney to return to baseline normal. Evaluation, stop immune checkpoints is our intervention to evaluate your patient in pre-renal, post-renal, and stop immune checkpoint and start steroid for this patient. And don't forget this screen. You should take in your, just keep this photo with you to just to give you a diagram to diagnose your patient, approach to your patient with AKI with immune checkpoint. And this is again immune checkpoint nephrotoxicity, either focal segmental, minimally changed, membranous, IgA nephropathy, both immune. Partial to complete remission has been achieved in most cases with discontinuation of immunotherapy and steroid use. With the family for immune checkpoint. Case 3, 42 years old male with 9 years history of Hodgkin lymphoma, referred for nephrotic syndrome and AKI. 42 years male patient with 9 years history of Hodgkin lymphoma, referred for nephrotic syndrome and AKI. Past medical history, hypertension, dyslipidemia, hypothyroidism, previously normal kidney function. Medication bisoprolol, rosuvastatin, levothyroxine, and pimprolizumab, again, these immune checkpoint inhibitors. History present illness, skin presented, we saw him already presented by swelling and orthopnea for 3 days, short of breath, and swelling for urine, nose, non-steroidal or other drugs, supplementation, examination, blood pressure is okay, a little bit lower side. With anasarca, his weight increased around 8 kilograms above his weight. With anasarca already, plus 3 edema, GVB also a little bit on the higher side, decreased breath sound at the basis with bilateral blue effusion, and protein 4 plus 1 blood, no cellular cast. No, what means no interstitial nephritis. This patient clear, no interstitial nephritis, Hodgkin lymphoma, nephrotic syndrome, AKI, and already received immune checkpoint inhibitors and came picture nephrotic syndrome. 6 week prior baseline creatinine is normal, albumin is okay. On presentation came by albumin, hypoalbuminemia 18, nephrotic range proteinuria 10 grams, acute AKI 400, creatinine from his baseline 67. CBC at baseline, calcium normal, ultrasound, no obstruction. I think the patient clear with HGN. What is differential diagnosis? Nephrotic syndrome with bland urine sediment, either minimally changed focal segmental membranous or nodular. With minimally changed, either primary or secondary to cancer or non-steroidal. Hodgkin lymphoma is common with minimally changed focal segmental primary or secondary infection. HIV, especially HIV, and drugs non-steroidal pamidronate, membranous either primary or secondary infection like hepatitis B or cancer drugs, and graft versus host disease. Nodular, we have two most common, this amyloidosis, diabetes, paraproteinemia. All this can lead to this nephrotic syndrome with bland urine. The differential diagnosis, just to keep in your mind this diagram to diagnose any patient with nephrotic syndrome and bland urinary sediment, either minimally changed focal segmental membranous nodular. Membranous gene and malignancy is the most common. And this is secondary, membranous nephropathy secondary in a third of the cases. Second most common cause in third of the cases. Malignancy may be, the first malignancy is Hodgkin lymphoma. The first one is minimally changed disease, and malignancy may be causal or coincident. Usually solid tumor like renal cell carcinoma, prostatic and lung carcinoma. Age more than 65 years, venous thromboembolism should stimulate suspicion of associated malignancy. Membranous nephropathy antigen, anti-phospholipase A2 receptors antibodies associated with one disease, but 20% may have occult cancer. And also nil 33% of positive patients with concurrent cancer, and the thrombodine factor also 18% positive have concurrent cancer, but maybe also expressed in some tumor cell. Membranous in third of the cases of malignancy, especially in solid tumors on older age, especially with patients with thromboembolism, presented with thromboembolism also. In this case, already screening for gene workup or serological screening is negative, ANCA is negative, complement is okay, hepatitis or negative, hepatitis C, B, HIV or negative, syphilis screen negative, even paraproteinemia screening, SPIP and immune fixation is negative, no monoclonal band, as we discussed in the first oncology presentation in details. and kidney biopsy was performed. Should do kidney biopsy for this patient. Autoimmune now negative, infection is negative, paraproteinemia is negative. This is the most 3 common workup for GN workup patient: autoimmune, infectious, and paraproteinemia. And this looks like normal. Capillaries are opening and okay, and this mesangial cell, no mesangial, even the mesangial matrix and cells, no proliferation, no expansion. And the patient, look here, podocyte already effaced, no podocyte, no food process already. The glomerulus membrane, no subendothelial or subepithelial deposition. And this capillary space, I think nothing is normal one here. Food process clear, food process, but here effaced food process effacement by electron microscopy, and this minimally changed disease. Minimally changed disease. This is our patient diagnosed here. Minimally changed disease. Minimally changed disease plus ATM. Presume the pembrolizumab associated drug discontinued already. Initiated prednisone 2 mg per kg, tapered diuretic, maximum 60 or 80 mg, and the furosemide, no renal replacement therapy required. Case for and your patient improving already after start steroid and stop immune checkpoint. Case for 45 years old patient with melanoma received cytotoxic T cell LE4 antibody and antagonist or antibody ipilimumab following 4 cycles, abruptly and sarca and nephrotic syndrome, hypoalbuminemia, proteinemia, nephrotic angioproteinuria, and normal kidney function. Biopsy was again compatible with minimally changed disease. Ipilimumab was stopped and the proteinuria resolved already following treatment with steroid. This is the second patient with minimally changed disease with this immune checkpoint inhibitor, and just stop the medication, start steroid. And also, if the patient recovered, you can resume his ipilimumab to treat his cancer already with the time. And this patient received 4 cycle ipilimumab and renal biopsy show minimal change. Prednisone started, and your patient is recovered already. And the proteinuria already recovered. This proteinuria, blue dots here, increased here already. The proteinuria. This is the 24-hour urine protein here by blue dots, and this serum creatinine is normal all the time, but the proteinuria increased and resumed here. Return it here. All this after prednisone here already started. Proteinuria already stopped, and the ipilimumab started again with maybe was adjusted dose like that, and the patient no recurrence again. Other gene nephrotoxicity of immune checkpoint inhibitors beyond tubular interstitial nephritis, either BUC, immune GN, IgA nephropathy, and membranous and amyloidosis. All this minimally changed disease, focal segmental, and GBM lupus, all can be associated also with immune checkpoint inhibitors. This also kidney immune related adverse event more than as we mentioned, this already mentioned in the slide before. All other differential diagnosis, both immune, podocytopathy, and 3 gene other than acute interstitial nephritis. Case 5, 39 years female patient with mesothelioma with mediastinal and liver metastasis treated with decortication 1 year prior. Referred for hematuria, proteinuria, post-therapy, past medical history, healthy before, normal kidney function, medication received pembrolizumab 4 cycle, precept. Okay, she received already this pembrolizumab again, would develop hematuria, proteinuria, post-therapy. What is this case? Also with ferrous urine, 2 months, proteinuria, hematuria. Examination is euvolemic and urine analysis 3 plus protein, 2 plus blood, red blood cell cast. This means we have active GN ongoing here, and the proteinuria subnephrotic range 2.5 gram per day with normal kidney function, hemoglobin is okay, and no leukocytes, no low infection, low leukocytosis. Addition of autoimmune infection screen. Autoimmune is negative, infectious screen is negative, paraproteinemia workup is negative, kidney biopsy was performed, and death, chronic endothelial damage. Here we see some subendothelial deposition here, I think, and this food process little bit effaced, and we'll see what is the diagnosis. This chronic thrombo microangiopathy. The other is this subendothelial deposition. chronic endothelial damage by electron microscopy. This is the chronic thrombotic microangiopathy, minimal interstitial fibrosis, no arterial hydronosis. The feature suggests this chronic endothelial injury, vascular endothelial growth factor, this AVI precept. With AVI precept, this medication, AVI precept, lead to thrombotic microangiopathy as a differential diagnosis for this subnephritic. This anti-vascular endothelial growth factor event is also released by podocytes, maintain endothelial cell and glomerular membrane integrity. If you receive this anti-vascular endothelial growth factor, lead to damages and lead to subnephrotic range proteinuria and lead to this thrombotic microangiopathy. Many other anti-vascular endothelial drugs like bevacizumab, avastin, and sunitinib, stent, and other this difficult medication also can lead to this disease, thrombotic microangiopathy, and this vascular endothelial growth promoter angiogenesis and tumor can be blocked by multiple points. And this different types of immune checkpoint and other medication from this vascular endothelial growth factor. And what is this vascular endothelial growth factor inhibitor and renal manifestation by each type of the disease? You can read if you like. And case 5, this proteinuria hematuria attributed to AVI precept discontinued already. Patient was stable to continue in pembrolizumab alone. Proteinuria resolved, renal function stable, and mesothelioma stable. But this patient just stopped this AVI precept. AVI precept, this vascular endothelial growth factor inhibitors already stopped. Everything resolved after that, and the patient continued with a checkpoint inhibitor without any side effect. Case 61 years old male patient with recurrent local bladder carcinoma, and 2014 diagnosed and already BCG installed. I think this patient already posted therapy 2015 also for BPH and prostatic carcinoma, and referred for AKI creatine 180, and the creatine before is normal 2 months ago. The patient is coronary disease, cabbage 2008, hypertension, dyslipidemia, diabetes, you heard, and abdominal aortic aneurysm, infrarenal open repair 2016. Yeah, strong post-medical history. And the medication is pramipirole and atorvastatin. Aspirin, ramipril already inhaled, atorvastatin, omeprazole also, and sitagliptin. We have here omeprazole, we have aspirin, all this, ramipril, all this will precipitate this AKI 180 plus what we'll see. And patient present by fatigue, weight loss, anorexia, no rash, active joint, no active arthralgia, no fever, no night sweat, no respiratory symptoms, exam blood pressure a little bit hypotension, but euvolemic. Urinalysis +1 blood +2 leukocytes, no dysmorphic red blood cells, no cellular cast. Investigation, albumin creatinine ratio 16 milligrams macroalbuminuria, and autoimmune infectious paraproteinemia workup was negative. All this done for any patient with AKI in onco-nephrology, autoimmune serology, and infectious workup, paraproteinemia workup should be done. And after that, the last one is kidney biopsy for this patient with this AKI, unexplained AKI. And this we show here multiple interstitial inflammation and fibrosis here by trichrome. By trichrome stains this blue stains this with interstitial fibrosis. Final diagnosis, mononuclear interstitial inflammation with non-causating granuloma. Where is this granuloma? This non-causating here, granuloma here. That's clear already, and it's just monoclonal interstitial fibrosis, interstitial inflammation with non-causating granuloma. Okay. Differential diagnosis drugs is like sitagliptin, case report already lead to granulomatous interstitial nephritis, non-causating granulomatous interstitial nephritis with sitagliptin. BPI can do that, and also infection, tuberculosis, mycobacterium, also secondary to BCG vaccine. Systemic inflammatory disease, sarcoidosis may lead to systemic lupus, Sjogren syndrome. Post biopsy urine for acid bacilli, sitagliptin, omeprazole already in whole, and hydromorphone for worsening back pain. Just only this. Urine acid bacilli already positive for acid bacilli seen. Urine BCR, mycobacterium tuberculosis complex detected by real-time PCR. TB clinic, CT chest review, not suggestive for pulmonary TB, and already other test positive for bacilli, Mycobacterium pufid, and failed to have Mycobacterium pufid secondary to BCG installation. Treated as a TB, started rifampicin, sambitol, INH, moxifloxacin already. AKI in patient with malignancy, common occurrence, negative impact across the curve of continuum, impacted chemotherapy regime, longer hospital stay already in AKI, lower cancer remission because you already stop or decrease or readjust the chemotherapy dose, and higher mortality from complication of AKI, whatever, or other complication from chemotherapy, infection, or sepsis. With a negative impact across the care continuum in patients with AKI and malignancy, as we mentioned, long hospital stay, infection, AKI, complication, dialysis, complication also. What is the definition of AKI? As we mentioned before, no need to repeat that already in our AKI presentation. Just increase the creatinine either more than 0.3 milligram per deciliter or more than 26.5 micromole per liter within 48 hours. Increase creatinine more than 1.5 from baseline or occurs over 7 days, or urine volume less than 0.5. Just remember 2.3 milligram within 48 hours or 26.5 micromole over 48 hours with decreased urine output less than 0.5 ml per kg per hour for 6 hours. Don't forget the staging, as we mentioned before, diagram approach to AKI with immune checkpoint inhibitor according to AKI staging. Stage 1, stage 2, stage 3, creatinine increase more than 0.3 or 26 or 48 hours, decrease urine output more than 0.5 ml per kg per hour. For 6 hours is stage 1, or increase 1.5 to 1.9 from baseline, 2 to 3 from baseline. This is stage 2 with decrease in about less than 0.5 ml per kg per hour for 12 hours, or increase creatinine more than 3 times the baseline, or less than 0.3 ml per kg per hour for 24 hours. Stage 3 more than just this will be, or more creatinine more than 350s is also is stage 3. Cause of AKI or risk factor, that's either sepsis, critical illness, as a patient hypovolemic shock, burn, trauma, cardiac surgery, hemodynamic instability, major non-cardiac surgery, nephrotoxic drugs, radio contrast agent, and poisoning like plants or animals or medication, with dehydration, volume depletion, advanced age, nail plaque, CKD, chronic heart disease, lung disease, liver disease, diabetes, cancer, anemia, all this risk factor for AKI. How common AKI causes? In general, causes of 1% of hospital admission, complicate 7% of hospital admission, 1% hospital admission with AKI, 7% complication from hospital admission, an overall population 550 per 100,000 per year, need for dialysis around 200 per million. 200 per million need dialysis per year. Frequency pre-renal around, most common is pre-renal 6%, renal 35%, post-renal less 5%. How should we approach to any patient with AKI in cancer? This is the most important point now. How you can approach to this AKI with cancer patient, either pre-renal, renal, post-renal. Don't forget this diagram. And the pre-renal, we have multiple causes here. You can read, and this renal, you can differentiate as RGN, vascular, tubular, whatever, or interstitial, and post-renal, you should rule out obstruction by ultrasound. And if AKI with cancer patient, either related to cancer itself or related to chemotherapy or drugs related, or other in general differential diagnosis, you should know all this differential diagnosis, cancer related, hypercalcemia, or you can this intravenous contrast, treatment related, sepsis, volume depletion, or hepatic sinus obstructive sinus syndrome, or capillary leak syndrome. Cancer related according to the type of cancer, or tumor lysis syndrome is a complication, or cancer therapy cisplatin. As we mentioned before, just read all this. This will help you to differentiate. Just keep this slide in you to give you guidance for differential diagnosis for AKI in cancer patient. Don't forget the most important now, this pre-renal, renal, post-renal, pre-renal as we mentioned. either volume depletion from GIT loss, sepsis, and other. And the most important, sinusoidal obstruction disease. We'll discuss this in detail in separate presentation. Hypercalcemia and the medication, diuretic ACE, ARBs, non-steroidal IV contrast, don't forget this, and the PPI. Intrinsic like GN disease, membranous nephropathy, minimal change, focal segmental, post-immune, membrane proliferative, tubular interstitial nephritis, acute tubular necrosis, tumor lysis syndrome, myeloma, cast, also nephropathy, and vascular thrombotic microangiopathy. Post-renal gas obstruction should rule out by ultrasound. Pre-renal is the most common etiology for cancer with AKI, either poor oral intake or sepsis or cirrhotic liver or heart liver, hypercalcemia. All this you should rule out, and hematological cancer, solid cancer, and stem cell cancer. All this pre-renal is most common, either from decreased oral intake or sepsis or hypercalcemia. All medication lead to this more coincidence of this AKI or progression of AKI. Etiology of AKI in solid cancer, the most common obstructive causes should rule out by ultrasound, nephrotoxic associated, either chemotherapy or PPI or non-steroidal or ACE or ARBs. Sepsis associated, this patient hypovolemic, hypercalcemia also associated, should rule out in this patient. Hematological with AKI, like multiple myeloma, leukemia, lymphoma, they're the most common tumors. And here, acute AKI in patient with hematological cancer, either related to tumor infiltration to kidney, obstructive uropathy, and also nephrotoxicity or other volume depletion, sepsis, nephrotoxicity agent like contrast or nephrotoxic medication, non-steroidal ACE, ARBs, or antibiotics or PPI. You should put all this in your mind also for differential diagnosis in AKI with cancer. The most selected etiology is tumor lysis syndrome, nephrotoxin chemotherapy associated with stem cell bone marrow transplant. How common AKI in cancer patient? AKI around 1 year risk of cancer patient, around 17 years in this Denmark studies. This Danish population-based studies on 1.2 million people, followed by 1999 to 2006, and around 37,000 incident cancer patient. 1 year risk increase 17.5%, and 5 years risk increase 27% in this Denmark studies. 1 year incidence of acute kidney injury, and 5 years acute kidney 27%. And here the risk, cumulative risk, the risk for AKI and the risk for mortality, and the risk increase already with the duration already. With increased duration, increase the risk of death and increase the risk of cancer. This is the incidence of AKI in cancer patients, 70.5 to 27, 1 year to 5 years risk. Incidence of AKI with malignancy or cancer. 8 weeks mortality, no AKI. If no AKI, 3.8%. If the patient reaches to a stage of failure of AKI, 61% mortality will be increased in 8-week mortality. If your stage, more failure on your kidney function, more risk for mortality. Causes of AKI in cancer patient, we have variable causes, either hypovolemic shock, sepsis, contrast, toxin obstruction, nephrectomy, tumor lysis, multiple myeloma, rhabdomyolysis, unknown other causes. You should know this. The most important ones is pre-renal causes, pre-renal cause, and the post-renal. You should rule out the first causes. As I mentioned, the most important risk factor, age is a risk factor, and the stage of cancer, and chronic kidney disease, previous AKI, diabetes, congestive heart failure, chronic liver disease, hypertension, arrhythmia, ischemic heart disease. All this, all risk factor to increase your AKI incidence in your patient. Renal carcinoma, AKI incidence 51% in patients with renal carcinoma, especially, and more than 10% post nephrectomy, and more higher risk of progression after nephrectomy, and pathophysiology for that. After you remove your kidney, that will lead to with hemodynamic surgical problem and decrease renal mass already after, especially in partial nephrectomy. If total nephrectomy, sure your patient will be end-stage renal disease. But if your partial nephrectomy will lead to hemodynamic during surgery and other pre-renal and renal, and maybe medication, interstitial nephritis, all lead to this pathophysiology of AKI for this patient. Renal function outcome were worse in patients who undergo radical nephrectomy, but similar for partial nephrectomy and thermal ablation. Further attention need to be here that the most worse in this systemic review meta-analysis in 20,000 patients already. Other patients is the most AKI similar across the malignancy. The renal function outcome worse for patients undergo to radical nephrectomy. This will be more worse than partial and thermal, but already not significant difference, but already shows this more worse with a radical nephrectomy more than a partial or thermal nephrectomy. What are the cancer-specific causes for AKI? Either vasculature or capillary leak by this or thrombotic microangiopathy by anti-vascular cerebral growth factor, tyrosine kinase inhibitor, and others. Minimal change disease and methylpimidronate lead to minimal change disease. Focal segmental with interferons, pamidronate, zoledronate lead to pamidronate here also lead to minimal change and focal segmental. And also tubular interstitial, all this already mentioned before, acute interstitial nephritis like this, and the crystal nephropathy, don't forget methotrexate lead to crystal nephropathy. As disease is specific in this diagram, what is gene thrombotic microangiopathy, especially anti-vascular and cerebral growth factor, like gemcitabine, bortezomib, mitomycin, doxorubicin, focal segmental pamidronate, interferon, antivascular and cerebral growth factors, crystalline nephropathy like methotrexate, and acute tubular nephropathy or acute tubular injuries, platinum, ifosfamide, bimetrexid, and other zoledronate, and tubular interstitial nephritis, immune checkpoint therapy, tyrosine kinase inhibitors, only two. This you can take copy and read again. And this by difference disease and antivascular and cell growth factors, the TMA, tyrosine kinase, acute tubular interstitial nephritis, and the other as we mentioned before. And if the drug name and the class is already an indication, and the renal toxicity with each one. And if we mentioned the immune checkpoint lead to acute interstitial nephritis is the most common, nivolumab and ipilimumab. All this, and the bimetrexid or acute necrosis, acute interstitial nephritis. You can read because all this repeated already. We mentioned our cases before, just as this summarized. Prognosis, ICU mortality, 55% of our patients. Hospital mortality, 60 is high percent already, and 6 months mortality, 73% in patients developing AKI on top of this cancer medication. 6 months mortality already, as we mentioned, 73% either related to shock, sepsis, hypovolemic shock, sepsis, toxin obstruction, and tumor lysis, rhabdomyolysis, and others. And with increased degree of renal impairment will lead to increase or hemodialysis need lead to increase more percent of mortality. On summary, AKI up to 30% on our patients seen in oncology department with cancer with chemotherapy, hematological neoplasia, kidney cancer, liver cancer, urothelial cancer, all this risk factor for AKI. The number of anti-cancer drugs grows every day. Nephrology evaluation, recognition, and early intervention. If concern for gene, kidney biopsy should be required if you think your patient with AKI and recovered after stopping chemotherapy and other risk factor for AKI, special PPI, non-steroidal, and the ACE/ARBs, or just stop and you treat hypovolemia, no obstructive, and still your kidney not recovered, you should go to kidney biopsy. If your patient presented by subnephrotic or nephrotic range of proteinuria and not recover after stop the chemotherapies, you should go to kidney biopsy. If your patient is active urine sediment clear, you should go to kidney biopsy. And close communication with an oncologist and with risk benefit with the patient. Patient with coexistent cancer and kidney disease are complex, multiple comorbidities, and require cross-disciplinary collaboration among oncology, pathology, nephrology, and other specialties. Kidney disease is common in patients with cancer and may adversely affect outcome, and treatment options. Improved strategies are needed to provide optimal cancer care for patients with kidney disease. And this is a final slide. Just as I know it's complex and hard to understand and to read and to see because it's a new, already growing branch in nephrology. But we should know at least a hint, and at least when you see any patient with AKI in oncology department or in your clinic or in your hospital during the consult, just approach to just open your mind what is differential diagnosis, when to approach just to supportive management or go to kidney biopsy as we discussed in detail. وأتمنى أن تكونوا استفدتم لو شيء بسيط تخدموا به مرضانا، ونسأل الشفاء دائما لجميع مرضانا ومرضى السرطان خاصة، ونعتمد الموضوع ده عشان خاطر خاصة مرضى السرطان. بصراحة من أمس الناس الحاجة لأي مساعدة طبية أو علاجية على قدر المستطاع مننا، وما تتأخر عنهم وما تقصر معهم، والله المستعان. لأن فعلا المرضى دول بيبقوا ضعاف جدا وتحت، يعني ربنا يرحمهم يا رب ويشفيهم، وإن شاء الله نكون دايما مفيدين دايما في الرد على الاستشارة لأي حالة مريض سرطان. والله المستعان، ونسأل الله أن يعافينا جميعا ويشفي مرضانا بإذن الله، ونسألكم الدعاء بالتوفيق والسداد والبركة في المال والأهل والأولاد، ونسألكم الدعاء بالصحة والعافية. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم، ونلقاكم بفيديو قريب إن شاء الله. السلام عليكم ورحمة الله وبركاته، ونترككم في رعاية الله وحفظه. السلام عليكم ورحمة الله وبركاته.